we talk about the growing concern of physician shortages, across a gamut of specialties, and so much of it is, driven by disparity in wages, disparity in opportunity for capital growth, and career security. And honestly, it also is kind of a self-perpetuating issue on the other side, where if there's a shortage, then you're basically asking a young physician to go into a very burdensome field of work immediately. But of course, some of the solutions that could come into play, I imagine, of course, is having a stronger tool set. If there's a lot more confidence in exactly the drugs you're prescribing, if there's screening measures that are placed, and I know that's another great conversation, at least I've seen in Africa-based trials, in terms of establishing very early and efficient screening measures. That combined with efficacious agents can certainly benefit a physician in this field now, right?
Absolutely, Kevin. And I do have to celebrate, one of the things that we have done well in this country is we do routine childhood screening. So if you're born in the United States, you will be diagnosed immediately with sickle cell disease. We have done that right. That was legislation actually signed by President Bush. So we've gotten that correct. The thing that you mentioned in terms of good medicines, that's where people like me come in, really trying to make sure that we're investing the capital that we raise into trying to innovate new therapies, powerful, safe therapies to treat the disease. And that's really what GBT has been founded on. We have one drug, as you already know, that's been approved, and it's available for patients today. But we have a number of therapies that we have, we're working on in our laboratories that we expect to bring ultimately to the clinic and to patients. It's by doing this over and over and over again that we do what we've seen in HIV. When I was a medical student at Yale, telling someone they have HIV was a death sentence. It's no longer a death sentence. If you take your medicines, you will live with HIV. Sickle cell disease, when you're diagnosed, is really a death sentence. It's not short death sentence, it's 40, 45 years, but the vast majority of people only live that period. We want to be part of bringing along simple oral therapies that you could take starting as a child and never get sick. We think we can do that in sickle cell disease. We think we know how to do it, but it's going to require continued investment, continued collaborations with leaders in sickle cell disease around the world, and we're excited about doing that.
That's excellent. That's great to hear. And speaking particularly to your team's drug, of course, some of the most recent discussion that we've had about it on the HCP side is its discovered benefit as we're uncovering more clear and indicative and consistent biomarkers, displaying exactly what these patients are at risk and exactly what we're talking about in terms of, prolonging, that guarantee of life and essentially trying to remove the death sentence label, at least in terms of observing which patients would be at greater risk of very severe comorbidities. It seems like your agent particularly may have benefit for this patient population. Dr. Love, do you have any thoughts on that, or is there any other lines of research where you guys are pursuing right now that you'd want to highlight?
Well, I would say, kind of going back to the science of sickle cell disease, we know this disease is about the hemoglobin sticking together, polymerizing.
Yeah.
And we also know unequivocally that if you can dilute the hemoglobin that sickles sufficiently, the disease really goes away. And the simplest example of that is people born with sickle trait who have roughly half sickle hemoglobin and half normal hemoglobin. They're not sick. So what we are trying to do is to convert sickling hemoglobin into non-sickling hemoglobin. And we are very confident that once we can start to get that proportion of the hemoglobin down to 50%, maybe even 35% or less, the disease will largely go away. Oxbryta in its current dose is modifying about 27% of the hemoglobin. We think we may be able to do better with alternative dosing strategies, But that 27% modification is clearly highly effective for many, many, many patients, but we can do better. And there are different ways that we could go about generating non-cyclic hemoglobin with different molecules, and that's what we're doing. So if we approach this like we approached HIV, with multiple strategies, basically going after killing the virus in that case, in this case going after polymerization, we think we can make this disease a very well-controlled chronic disease from which you do not suffer and you do not die prematurely. That is our goal, that's our vision, and that's what we're investing in.